Welcome back. This is the third video for fluid optimization part, which we were discussing. And in this third video, we'll discuss the clinical application of fluid in electrolytes and what is there inside this video. Brief about this. In this video, we are going to discuss the administration of fluids. There are a few important points, and we'll focus about these important points. The first thing, whenever there is a patient, what usually we do, and if we have already discussed the indications for fluid optimization in various different 5 groups of patients, and accordingly, suppose we have decided that this patient needs fluid administration or optimization, there are few steps, and in this video we are going to discuss just to summarize the things. Let's go to the various slides that is available here, and this is the most important slide. This is giving us the summary of the things what we are supposed to discuss in this video lecture. The first thing is administration of fluid. The second thing is monitoring, how much we have already given, what is it further required, or it is required to stop the IV fluid administration further. So monitoring is important. After monitoring the various ways, the important thing is we will be discussing the various replacement regimes. There are 3 important replacement regimes in this one we are going to discuss. And in the post-operative period, especially suppose we have done some surgical procedure, and especially in the post-operative period, how to assess the volume that is required or that is there inside the patient, sufficient or not, how to assess it. So these are the things we are going to discuss, and under administration of the fluid, we are going to discuss what is the amount of volume depletion, assessment of that, followed by some rules to give fluid resuscitation, right, under administration part. Now, during assessment of volume depletion, 3 important things are there: the body weight assessment, the hematocrit assessment of the patient, and depending on the body weight and hematocrit at the time of admission, we can calculate the volume depletion. Okay, so let's go through the further slides that is available here. Now, how to administer the fluids? The first part. Here you can see, first of all, we are supposed to assess the volume of depletion, and that is the first thing in these type of patients we must do. And for assessing the volume of depletion, there are 3 important useful points for all of us. First of all is body weight on admission. Assess it. Recent accurate body weight when the patient was healthy. If it is available, very good. Why? Because if we are going to measure the body weight during the admission, we can very easily estimate what is the acute weight loss, and usually the acute weight loss is usually water. So mostly it is due to loss of water, and that can be replaced. So for assessing the volume of depletion, body weight is required, body weight of the patient. Then hematocrit on admission is required, and recent hematocrit during normal health is required. And degree of hemoconcentration, it will tell us, and this degree of hemoconcentration, if the patient is having let's say higher hematocrit, but there are other features suggestive of dehydration like mucosa, the mucosal hydration or skin turgor, it means this hemoconcentration is due to the fluid depletion. There's so many causes. The fluid may be lost. We have already discussed the various causes, the various groups, right? So measure the weight of the patient if possible. Then hematocrit on admission. And finally, using this weight and hematocrit, we can calculate the fluid depletion. Here you can see the L is denoting fluid depletion, and this PCV1 is normal hematocrit. PCV2 is the current hematocrit of the patient. We are going to subtract the current hematocrit from the normal hematocrit, and it should be divided with normal hematocrit. Then it will become a ratio, right? Then out of this PCV1 minus PCV2 divided by PCV1, we are going to subtract two things. Weight of the patient in kg, in numbers, we are going to subtract it, and this minus 0.7, this should also be subtracted, and it will give us the fluid depletion in liters, right? Okay, clear? Let's say normal PCV1 is 45 for that particular patient, and presently the current hematocrit is somewhere, let's say 47 or 48. It should be calculated like this, and sometimes, yes, in cases of hemorrhagic shock due to excessive bleeding, PCV2 could be below the normal value also. So just take the values, different values that is available with the patient, measure the weight, and you can use this equation to calculate the fluid depletion in liters. Now, some important observations during the management of these type of patients as far as the fluid management is concerned. The serum urea is usually raised more than the serum creatinine. And why? We'll discuss later on. The serum urea is more than the creatinine, serum creatinine, in these four important cases. In cases of dehydration, serum urea is raised. Acute renal disease, raised. Gastrointestinal bleeds, raised. And all the conditions leading to acute proteolysis, again serum urea is slightly more raised as compared to the serum creatinine. This is one of the observations during the management of these patients. Then, as far as the signs of extracellular fluid depletion is concerned, it could be lax skin tone, sweating will be reduced, and mucosal site will be dry. Usually misleading factors could be like age and fever and tachypnea. These factors can also affect the fluid depletion, extracellular fluid. And signs of intravascular volume depletion like hypotension, low blood pressure, and tachycardia, that is increased heart rate, these may be present in any patient, but these things are usually unreliable, and they usually occur with loss of 10 to 15% of total body water. So it's better not to wait for this time. Just have a clinical judgment and just manage the patient before this scenario is going to be seen by us. Just act quickly. This is my advice, right? So these features, they are usually unreliable, I would like to say again, and they usually occur with loss of 10 to 15% of total body water. Now, suppose using this weight and hematocrit, we have calculated the fluid depletion. We have assessed the volume of fluid required. What next we are supposed to do? There are some rules and rules to follow on how to give fluid resuscitation. We'll take up with young fit patients with normal cardiac and renal function. In this case, up to 15% of total body water even we can give by rapid infusion in young patients, fit patients. Whereas in cases of this young patient, uh, a typical regime for 70 kg man, if you are taking or male or female, 1 liter of 0.9% saline should be given over 2 hours, and further 1 liter infusions of 0.9% saline over 4 hours. Each should be given until it is corrected. This is a typical regime for 70 kg weight in young patients, fit patients. Whereas in elderly patients, more than 50 years we are taking here, and patients with renal or cardiac dysfunction, the infusion should be slow to prevent acute intravascular volume overload in these group of patients. So always take care of this. Elderly patients, infusions should be slow. Don't overload the patient. Example, 1 liter 0.9% saline we can give over 4 hours in this group of patients, the elderly one, followed by 500 ml 0.9% saline over 4 hours with regular review of vital signs including chest auscultation to rule out any pulmonary edema or any other chest complication due to fluid overload. And even in sometimes, if required, even in this group, if more rapid replacement is required, you can give, but monitoring is always required in critical care in this group of patient. Okay. Now, after administering the fluid, following the rules of replacement, how to monitor the fluid optimization. This is important, monitoring. This monitoring part we'll discuss in this one. Now, methods of assessing the progress of fluid optimization. This we can do by observing the skin turgor and mucosal hydration, right? It changes slowly. This mucosal hydration changes slowly after optimization, and that's why these are unreliable guides. You cannot rely on them. Only solely you cannot rely on them, just skin turgor and mucosal hydration, right? Another method of assessing the fluid optimization is urine output, 1 hourly urine output. It's a good indicator to renal blood flow, indirectly relates to intravascular fluid volume and cardiac output. It's an easy and reliable indicator of adequate blood volume repletion. But we'll see very quickly. We'll go through how much reliable it is, this urine output 1 hour, and commonly used minimum is 0.5 ml. This is normal. This is a minimum normal is 0.5 ml of urine per kg body weight per hour, right? But this is not a good indicator of total body water. May be significant intra and extracellular depletion in presence of an acceptable urine output. Means what? Even if the urine output is within normal range, there may be presence of significant ECF or ICF depletion in the patient, right? So we cannot say that 1 hour urine output is solely perfect and it's a good indicator. Then the third one is monitoring of serum urea. An approximate guide of replacement it provides, and if only provides the approximate guide if the renal function is adequate and there is patient is not suffering from any GI bleed and there is no history suggestive of any condition that is leading to proteolysis, protein breakdown. patient should not be a or managed or follow-up case or post-traumatic case, or patient should not have any history of recent road traffic accident, severe road traffic accident leading to myoglobinuria and all these things. So no proteolysis should be there, right? Then comes how to monitor fluid optimization. If patients require urgent surgery and require fluid optimization prior to anesthesia, then sometimes we will have to infuse the fluid rapidly. And in that case, we should monitor the patient in ICU or HDU. Our aim of fluid management, there are two aims. Don't underhydrate the patient and prevent overhydration of the patient. That's all. These two are the basic aim of fluid management in any type of patient. Don't underhydrate, don't overhydrate. So principle what we can follow in this thing is to replace whatever is lost. And success of fluid management, it gives what? A short, uncomplicated post-operative course for any operative patient. And if not successfully managed, the patient will land up into ICU care. So very important is fluid management. Another principle is to replace sodium, potassium and water loss. Loss from where? Loss from urine, vomiting, diarrhea, high output fistula in the patient, any stomas that is present. Then third space fluid loss like ascites, grains of ascites or fluid edema. Whatever is applicable, just replace the loss. So water loss is around 2.5 liters per day, and this 2.5 liters of water is being lost through the insensible loss from skin, the respiratory and GI tract, and urine. And it is also lost usually in sepsis, the ventilation during the mechanical ventilation for longer duration, and diarrhea. Or not only mechanical ventilation, even normal ventilation also. And vomiting, high output fistula, and polyuric renal failure. So in these cases, water loss is supposed to occur around 2.5 liters. Just remember this one, 2.5 liter average per day. And sodium, 100 millimole per day in urine, and this is lost in the pyrexia, diarrhea, vomiting, and again high output fistula. As in elderly, this urine concentration is less effective, not able to control properly in the elderly age group, so don't give dextrose infusions. If you are giving dextrose infusions, that is going to predispose the patient for hyponatremia, right? Reduced sodium in the blood, right? Due to overdilution, as dextrose is hypertonic initially. Now potassium, around 80 millimoles per day, daily loss. In urine, loss during high fever or diarrhea and vomiting. Again, high output fistula, this is the common thing almost. This water, sodium and potassium, they're lost on an average daily basis. And for that, we must replace all of them. These are the commonly used replacement regimes. Very quickly, the examples, the regime number 1. And this regime number 1 is only for adult patients with no significant comorbidity. Gives 3 liters of fluid, 200 millimole sodium and 80 millimole potassium chloride in 24 hours. But the disadvantage is for this regime is it takes no account of patient age, size or weight of the patient, cardiac function, or fluid loss. This is the disadvantage of regime 1. Advantage, you can give for adult patient with no significant comorbidity. And for this, 1 liter of normal saline 0.9% with 40 millimole of KCl over 8 hours, followed by 1 liter of normal saline 0.9% with 40 millimole of KCl again for another 8 hours. And finally, the third 8 hours, the last third of the day of the 24-hour period, 1 liter 5% dextrose over the last 8 hours. So this was the first regime. Now this is the second regime. This adjusts the fluid given to fluid lost. But monitoring is required and it needs an hourly fluid balance chart and infusion pumps. This second regime is more suited to patients in ICU. Normal saline should be given at 1 milliliter per kg per hour rate, and if required, the colloid can be used like gelofuscin or 5% dextrose. The 5% dextrose crystalloid fluid challenge can be given to maintain the CVP between 8 to 12 cm of water or blood pressure systolic more than 120 mm of mercury. In this second regime, especially meant for ICUs, 10 to 40 millimole KCl in 100 ml 5% dextrose via central line if patient is suffering from hypokalemia, or let's say if potassium value is less than 3 milliequivalents per liter. This second regime is for patients admitted in ICU care. The third regime, these are the general regimes we are discussing. The elder hay pediatric regime, it is for all ages and all body weights, except it should not be given in extreme starvation. For fluid replacement, fluid volume for 24 hours, according to the weight, for first 0 to 10 kg weight, 100 ml per kg for each kg calculated. The next 10 kg, that is from 10 to 20 kg, 50 ml per kg for each kg, again calculated. And over 20 kg, for each kg, just add 20 ml to that. For example, suppose a patient is there averaging, let's say weight is 50 kg, and for that first 10 kg means 100 ml per kg, means 100 into 10 is equal to 1000 ml, that is 1 liter. Okay, keep in mind. Then 11 to 20 kg, 50 at the rate of 50, this will come as 500 ml. Add it to the 1 liter, that it then becomes 1.5 liter up to 20 kg. Then 50, the total weight, minus 20 kg, the remaining is 30. For 30 kg, each kg 20 ml. So in this case, again it will come as 600 ml, right? So add again this 600 ml to 1.5 liter, it will become 2.1 liter. So around 2100 ml fluid is required for a 50 kg weight person, right? The third regime. For electrolytes, sodium should be replaced at the rate of 2 millimoles per kg per 24 hours, and potassium should be replaced 1 millimole per kg per 24 hours. Fine. So assessing the volume status in post-operative patient, this is the last subtopic in this video. How to assess the volume status, especially in the post-operative patients. These are the few important things: history and examination, the observations chart, the fluid balance chart, the blood results, and chest X-ray. By these things, we can assess any patient the post-operative period, and especially this assessment is after 24 hours of post-operative, 24 hours after the operative procedure, the next day. So we are just taking up two important conditions. Either the patient will be underhydrated or overhydrated. Underhydrated patients, we are mentioning it as dry patient here, and overhydrated patient, we are mentioning like overloaded patient, right? So dry patient in history and examination. Nil per oral several days pre-operatively if the patient is nil per oral. Patient feels thirsty, dry mouth will be there. Due to presence of diarrhea or vomiting, patient may be dehydrated. Low JVP is there. Dry mucous membranes will be there, and with reduced skin turgor, right? Whereas if the patient is overhydrated, patient will not feel thirsty but will have raised jugular venous pressure with normal skin turgor. Over the dependent part of the body, edema may be there, and sometimes evidence of pulmonary edema on auscultation we may have, right? So underhydrated and overhydrated. During history and examination, we can assess what is the status of the patient after fluid optimization. Then next is observations chart. Dry patient, there will be falling blood pressure but rising pulse rate. Low central venous pressure will be there, and that will not rise with fluid challenges. Weight several kgs below the pre-operative weight. So these are the characteristics of dry patient or underhydrated patients. An overhydrated patient, BP may fall with fluid challenges. We are giving fluid, but the BP is falling. Usually there is no tachycardia, but the central venous pressure is high, and that rises, and whenever we are again subjecting the patient with fluid challenges, it will plateau up. And why we are giving fluid challenges? BP is falling, right? But otherwise patient is overhydrated. And in this group of patients, the weight will be more, several kgs above the preoperative weight. The third thing is fluid balance chart. Ask the staff to start an hourly fluid balance chart. What we are supposed to do is add up all fluid loss, like in urine output, wound, stoma, and fistula drainage, and subtract from all IV or nasogastric and oral fluids what we have already given to the patient. Just subtract the fluid loss from this, right? If the patient is underhydrated, you will find several liters of negative fluid balance with urine output less than 1 ml per kg per hour. If the patient is overhydrated, several liters of positive fluid balance will be there. Urine output may be low because of heart failure or renal dysfunction. So these group of patients, please be careful. Don't overhydrate the patient. Cardiac diseases and renal diseases. Now comes the blood results. In underhydrated patient, the sodium and potassium, creatinine and urea all will be towards the higher side. They will be raised. And especially the urea creatinine, if we are comparing, urea will be more raised as compared to creatinine. Whereas in overhydrated patient or overloaded patient, the patient may have a hyponatremia features. The features of hyponatremia, low sodium will be there. The chest radiograph, X-ray chest, dry patient, there will be no evidence of usually pulmonary edema, no evidence of any effusion, but the overhydrated or overloaded patient may have features of pulmonary edema on chest X-ray, or chest radiograph, and even features of pleural effusion. Alright, so that is all regarding the fluid optimization of any patient, and then we have discussed various things including how to assess the patient in the postoperative period. So thank you very much for going through it. Take care and stay safe.